I'm in the same club as Richard and Trish Bradford, Rotary Club of Bradford West, in Bradford, just outside, in District 1040, and I've been a consultant ENT surgeon since 1986, so I'm on my final year. But one of my passions for all this time has been dealing with deaf people, hard of hearing. We can debate how we call each other, and in recent years, well, 30 odd years, doing cochlear implants. So, if I can do this, the question is, can you see deafness? So who is the deaf child amongst them there? They all look so happy. One of my favourite people, and getting to know her background story, is Helen Keller. And she had some form of probably viral illness in very early years of her life, and was both hearing impaired and blind. And one of her many, many quotes is that blindness separates you from things and deafness separates from people. So on that frame, what I want to do is talk about some of the basics of how you hear. So I'm going to be a little bit medical. If I lose you or you lose me, please interrupt, because it's semi-formal, it's informal, it's to understand what's going on. The impact we know medically about hearing loss, and the importance of early identification, which we now call newborn hearing screening. Deafness has no boundaries, it has no borders, and I'm part of the World Health Organization and do a lot of work out in sub-Saharan Africa. We've been going there for the last 14 years. And whilst we've been doing cochlear implants in this country, I've been doing them since 1990. We set up an implant program in 2014, and it's starting to have an impact within Africa, but I'll concentrate on some of the work we've been doing in Malawi, and what happens. It puts a bit of light on how good the NHS is. So this is how
Christopher, can you speak directly to your microphone, please?
I'm right in front of it.
Yes, that would be better. Thank you.
Right, hopefully that's clearer. So, so sound energy comes in, picked up by your ear, comes down your ear canal to your I call your lug or your eardrum, through the middle ear, and then to the nerve of hearing. And I've drawn a line. Mechanical, it's called the conductive hearing loss, and then in the inner ear, if you have a problem there, it's a nerve hearing loss. And interesting, there's a lots of theories. Why has the human being developed hearing of this sort of mechanism that's so delicate? So what we have is the transformation of mechanical energy through into the fluids of the inner ear. And you've got tens of thousands of little hair cells. And if you think of seaweed in the sea wafting backwards and forwards as the waves move in, sound is just waves. And this is a representation of the piano keyboard, because at the entrance to the inner ear is high frequencies, and then the longer frequencies, the low frequencies, come right up to the apex of the ear. It's not a straight tube, it's a snail, so hence the word cochlear is Greek. If some of you have got hearing aids, you would have had a hearing test and an audiogram. And to put it easily, people say, well, if you've got zero hearing, that is perfect. And if you've got 100 decibel hearing loss, you're totally deaf. It's not a percentage. This mathematically is a logarithmic scale, so it is very complex sometimes to understand, but the principle is having normal hearing, a mild hearing loss, moderate, and then severe to profound. And you can see some of those items to depict what those frequencies might be. So the impact of losing hearing So if you have a mild loss, you still can hear people in what we nickname the speech banana. So as long as people talk clearly and directly to you, and there is minimal background noise, most people will cope. Hence, the volume of the television goes up. I mean, one of our daughters lives in Italy, and she came home one time, and having not seen her for a couple of months, she disappeared into the another room. I thought, oh well, we haven't seen you for a couple of months. That's fine. She came back and said, well, how do you two old folk manage the volume of the television is so loud? And that's really when we realised that as parents, my wife and I were slowly just adapting to our hearing needs, and hence it's volume. So hearing aids give you personal amplification. So moderate hearing loss, you start to lose speech and impact you on societal interests, and obviously severe. You might see the plane going overhead, but you might not hear it. And only if you're close to the lawnmower do you actually hear it or feel it. So there is some marked importance about what is going on with your hearing. And we divide hearing loss into congenital, i.e. you're born with it, or you acquire it from various ways because of disease or from genetics and things like that. So it is so important to diagnose a hearing problem at any time, but more so with children, because there's failure of education, and if you have problems with education, you don't become a taxpayer and you have social isolation, and there's reasons that you have increasing ill health. We've now shown very clearly that dementia is related to lack of stimulation, be that sensory from vision or hearing. But it's so important that people keep on going and receive that stimulation. So newborn screening came in 2001 as part of the initial screening programs, and we brought that into our hospital in 2002. And by 2006, every hospital, every maternity hospital had access to the screening. And it's been so successful, they've stopped auditing it because over 98% of all babies screened, both born in hospital and born at home or born outside of area, are screened within 4 weeks, usually before they actually go home. So identification is important. And what I've put there is the hearing cortex, the part of the brain that is allocated to hearing, needs to be stimulated well before the age of 5. And if you don't do that, the part of the brain is used for other things. So you get heightened vision and heightened sensory touch. So if you've ever seen Braille on a lift button, you think, how the heck do anybody understand what that is? But you adapt. Hearing loss has no boundaries, and the World Health Organization is estimating that 900 million people by 2050 will have it. So the current date is there's 554 million people worldwide has a disabling hearing loss, and that is defined as 40 decibels or greater. So people need amplification. They're not performing correctly. They're outside of the speech banana. Try not to be too complicated, but this is down the, but it's probably easy to say the prevalence of hearing loss is lower in high income countries. But as you come back up, you've got sub-Saharan Africa at the top, and South Asia is very, very high. So you can get some idea that poverty and education and national income are all relevant to health and hygiene and hearing. So it's where you're born. You can be anywhere. There are genomic maps to show that mankind started off in the middle of Africa and then spread around the world, and the different gene pathways have followed man across the moving shelves of continent. So I've just spent 2 weeks in Japan with the main geneticists of hearing, following the DNA changes over the years as man has migrated out of Africa. So we have a hearing problem. We've diagnosed it. What can we do about it? And I think classically you all know about the classical hearing aids, and the NHS ones are not to be poo-pooed. They are not made by the NHS. They are bought in from the private companies, and they actually buy high-end quality hearing aids. So you won't get in the ear canal type of hearing aids which will just sit in your ears, but they are functional and help. If for various reasons you can't hear, there are bone conductions which vibrate to the bone, and then there are now little magnets, little middle ear implants that you can clip on. These are just 2 or 3 millimeters in size. You can clip onto the little bones that help shake them. But remember, the sound waves are just vibrations. And then if the inner ear is trouble, you can use cochlear implants. Or if the nerve is a problem, you can actually put implants into the brain stem, which it's quite specialized surgery, that one. So here's just a schematic of how the little hair cells work. They move to the vibrations. Those vibrations set the electrical currents. All nerves are sending signals all the time, and this is the pulses that you hear. And remember the piano keyboard, depending where the sound waves hit, you'll have high frequencies and low frequencies, and depending on the complexity of the sound wave, it's like playing a piano keyboard. You recognize tunes, and hence voice is just melodic sounds. So if the little cells are poorly, you don't hear. There are various areas where the hearing loss can occur, but in reality, regarding a cochlear implant, the principle is it is a surgically inserted hearing aid of which there is a special electrode that is fed into the inner ear. It's only 1 millimeter or 2 in size, and platinum electrodes stimulate the nerve of hearing directly because the inner ear is not working. And this is some schematics of the principles of the things. So implant has a hearing aid as we know it, microphone, battery, a transmitter coil, and then there's a package underneath the skin, and the electrodes are fed in surgically into the inner ear to get some idea of getting close proximity to the nerves of hearing, stimulated, and goes up to the brain, and you either help to hear or relearn again your hearing if as an adult you are postlingually deafened. So what are the outcomes? I've got a couple of videos. These have been transmitted on the television, so there's formal consent. This is Jane Martin, our teacher of the deaf.
Oh, George, where's that drum?
Teachers of the deaf will also come out to school and to your home to get to know all the members of the family.
No, I don't think he's going to turn. Do you, Vicky? No.
George Marks is 14 months old and is currently under assessment.
Ready, go. Are you seeing him turn to any environmental sounds when he's wearing his hearing aids? Any sounds at all?
We don't see him turn to anything at all at the moment.
Okay, so banging the drums clanging the clangers, nothing, and he's got hearing aids in, and there was not even a blink. So here he is now, he's 3 years down the line.
How would you get there? How would you get to where you're going? What's that?
In a car.
In a car. Do you know what this is?
A double-decker bus.
Yeah, and do you know when you're going to be going on a double-decker bus soon?
And harvest parties.
Yeah, it's a special bus, isn't it?
We're going on one in Italy.
Are we? I don't think it's a double-decker, I think it's a coach. Who else do you think will be on the bus at Harvest Party?
Everyone is.
Everyone in the whole wide world?
No, everyone in our class.
Oh, who are you looking forward to seeing there?
Jane. And Ben.
And Ben, yeah, that'll be good. Any girls going?
Yeah, every single girl.
I'll move on there. But just to show you that he's picked up an accent and there was little eye contact. So it's important that he can hear those words without lip reading or getting any stimulus from his mum. So this has made a huge impact in how children are now educated, and basically all our children no longer go to a deaf school, they go to mainstream with support, and this has had a huge impact in the finances of cochlear implants because it's cheaper, but it's expensive, but you can see the benefits. That child would not be able to do that at the age of 3. So sub-Saharan Africa, where we've been working, is a problem. Wakisa Mawafu is the ENT consultant that we work with in Blantyre in Malawi, and it's important that the percentage of the population you can see in there is, it's 3 times as much in there, and even in children it's it's many fold. Now, the important thing is recognizing hearing loss, but we know that clinically a lot of the diseases are preventable, such as good hygiene, not to use medicines, complications of birth. I mean, the mortality rate, birth mortality rate in some sub-Saharan countries or out in the sticks is horrendous. And maybe 1 in 10 mothers die within the first month of delivery of the child, let alone the neonatal mortality rate, which again is in double figures. But measles, mumps, meningitis, a lot of these conditions are now transformed by vaccinations. Poverty has an impact. The World Bank's classify countries into high, middle, low and low incomes. And just to give you some idea, Malawi is down in the African there, but you can see a lot of the Central Africa and Sub-Saharan Africa is low or low income countries, and to live on $640 a year compared with the average of nearly 80,000 is chalk and cheese. But obviously things are proportionally cheaper. But to give you some idea, petrol prices are the same as in Europe. I'm trying to... Africa is a massive country. Just see what you can fit in. United States, India, Eastern Europe, China. It is a huge country. And Malawi is tucked in between Mozambique, comes round, and Zimbabwe, and then you've got Tanzania and lovely other countries beside it. That was just an idea to give you some idea of where the hospital is in relation to Malawi. So why have we been going to Malawi? Well, we think we can do some help. It's a great country. It's on a high plateau. It's part of the old Nyasaland Rhodesia, so the climate is quite conducive at times. Now, you think you have NHS waiting lists. This is an outpatient clinic, waiting very orderly, usually in the sun, just waiting to be seen. Anne and I and other colleagues go out for the month of April and November, and it'll take them a few days to come to the hospital and just to be seen and to help out. I don't think I've got a slide of it, but I've lost the movement. Yeah, this is the ENT unit when it was first built by charity money in 2014. Very functional. You've got outpatients, outpatients departments, theatres, and then the wards. So Blantyre is the commercial capital of Malawi. Lilongwe is the administrative capital. And over the years, we have been training clinical officers. These are basically paramedics. They've no medical training, no nursing training, but we have them for 2 years, giving them basic sciences and then 18 months of ENT. And this really helps us. So we've only got one consultant, 2 registrars, middle grades, and 3 clinical officers at the hospital. And we're treating 21 million people. So the head count per doctor is phenomenal. So you can moan as much as you want about not being able to see your GP. They don't moan. But how do we help? I mean, through Rotary, we help train the people. And because we've been going out for a number of years, we understand what they need. So continuity of care is important. And that's my wife been packing up things. That's our garage, which is, I wouldn't say a dumping ground, but between Malawi and Ukraine, we can't get our cars in. It's a 4-car garage, and we just physically can't get the cars in these days. And what we don't ship in by container, because we work with CART, the Christian African Relief Trust that lives in Huddersfield, we take our bags, and most times the bags get to where we go, and then we fit them into the car. And believe it or not, 4 of us did get into the car with suitcases on our knees. And that's Wakisa meeting us at the Chilika International Airport. So we teach the clinical officers the theories, we teach them procedures in outpatients. Disease is quite gross, it's quite significant. And the wards are unisex. We have children, adult females and adult males, all under the one room and one roof. There's no potential barriers, and there's something like 40 beds, but every patient has a guardian. The nurses don't treat the patients. They give them the medicines and do the observations, but the care is by the guardians. So bed bathing and feeding is to the person. Nobody's allowed to be admitted without a guardian. We've got high-tech facilities to look at x-rays, and we've imported a lot of equipment to be able to do and train the surgery and get people organised without telling them what to do. We hint how to do it, and we've had the joy of actually bringing some of the nurses back to the United Kingdom and embed them in with the hospitals. A great bunch of people. We teach them all skills, and at the end of the day, we take out boxes and we fill them with equipment which is theirs to look after, and they will take them back to their villages to do basic diagnostics. We have a very active WhatsApp group because at the moment we're only 2 hours ahead of, yes, we're 2 hours ahead of them. Yeah, we're 2 hours ahead of Malawi at the moment because of we're winter time. So they post on problems and we can give them directions because we know what is going on there. And this is a map of where our students are. Malawi is about, I think, 1,200 miles long. The Lake Malawi is the 10th biggest freshwater lake, but it will take you about 5 days to drive from Blantyre to the Northern Territories. There is a joking road called the M1. That motorway, that road has the highest death rate in sub-Saharan Africa. It's absolutely criminal because they've got massive lorries which basically have no tread. They don't believe in MOTs, and you think about potholes, they're insane. Yeah, patients come to us, we go out to them, and certainly after a cyclone Ida and Freddie, we came in at the tail end of them and went out to camps to look at people because the houses were washed away and things. So we used the containers to look at ears and find out disease. So you think, why do cochlear implants, which are very expensive, I mean, they're about £12,000 a piece, but we've introduced otological surgery at a high standard over the years. We've been teaching the local surgeons what to do. We run courses both in Harare and Blantyre to the sub-Saharan consultants, and through charities they've built an audiological unit which is actually pretty good. It's the nicest place because it's got air conditioning in it, which is a joy, but it's got the soundproof booths, and we felt that we could implant people. This is a Nipa.
Ball.
Bird.
Cow.
Cow.
She's not looking at anybody.
Tree.
Pencil.
She goes behind her.
Pencil.
Monkey.
Monkey.
Baby.
Baby.
Flower.
Flower.
Butterfly.
Butterfly.
Banana.
Banana.
Ambulance.
Ambulance.
Elephant.
Elephant.
So you can see how clearly it is. Chichawa is their language, but she is able to speak in English because she's been taught that, and that is we call open set. So she's not getting cues. She is, Chico is literally behind her. So we only do children who have lost their hearing. We don't have newborn hearing screening, which is something that we need to come for. So over the 14 years, we've got 19 children and 2 adults. We're just taking our time. We do a couple each time I go out there because we need to support them, and we do get support from the companies. We don't want not help them in the future because they're costly to run. And when I've talked about cost, this is a bit slightly old. This is 2015 data, but the principle, this thick blue line, is Malawi. We struck a line at here to make an implant affordable. It'd have to be something in the region of about $3,000, but an implant probably discount is about $10,000 in reality. So most other sub-Saharan Africa and South African countries can gain access to implants better than Malawi or other places. It doesn't have any great mineral wealth compared, say, with Botswana or Zimbabwe. So how we've managed to do that is with liaison with our implant unit, we have adapted what we call the children's implant profile. It takes a number of weeks, even a few months, to actually see if a child or that matter, an adult, is suitable for an implant. There's a lot of testing, and it's a multi-faceted team: teachers of the deaf, audiologists, surgeons, radiologists, pediatricians, things like that. We've got the equipment, we've got the staff who've been trained up, and as I mentioned, we only tackle children who had the power of hearing because they're a lot easier to rehabilitate. And the technology has improved because the processors are now we call rechargeable batteries, because we can take out thousands of hearing aids with us, and 60,000 hearing aid batteries were last time we got stopped at Johannesburg Airport, when we were only told that we were allowed 20 batteries for hearing aid use, but we had 60,000. So they shrugged their shoulders and closed our cases, and we walked away. But we get a lot of support from Medel, which is an Austrian company, and a lot of rehabilitation now is online, and most people have got mobile phones. Airtel has got superb coverage. So we're slowly spinning off and making people aware of a hearing problem and the need for amplification. So power shortages, they don't have power all the time. So very simple, for about $20 you can make up solar panel generators, and you can see the health and safety, people walking on the corrugated roof without scaffolding or anything, to put the solar panels and screw them down so they don't get reallocated. So during the day a battery will be charged, and at night that battery will charge the implant. So with a lot of support from Rotary, the World Health, the Ear Trust, which is my local charity that I started our implants, in Bradford we have a very active Malawi relief fund. There's quite a lot of Muslims out in Malawi, and Medel, which is the implant company, and we set up an organisation called ENT Malawi, which is for the clinical officers and the couple of registrars. So one little take-home message really for Rotary is fact of life. We're not getting any younger, and we need to be inclusive. And one, again, fact of life is as we get older, so does our age, and we become more reliant on hearing aids. Well, that covers most people's needs, but in meetings, unless you bring in technology and support, a lot of people will wither by the vine. So we've put in amplification, loudspeakers, and Trish alluded to captioning, and that really has transformed it, because Trish, you probably appreciate, has a significant hearing problem, and our current president is very, very deaf, and you have to get his attention before we can sort it out. But even in meetings, deafness is not seen, but any organisation, and obviously Rotary in this context, needs to be aware that if we're putting on events for ourselves and for the public, we need to be inclusive to support people with disabilities. And we're all aware of wheelchair access, and probably I'm not all up to date with people with sight problems, but auditory problems is so important. So I'll leave that, and this is the implant centre that we built and had a lovely royal opening. So this is the Listening for Life Centre, where our patients are seen and treated. So it's in the grounds of the hospital, but it's not the hospital. So it's a nice place for people to come and be seen. So I'll say adieu on that, and happy to take questions.